approach to tobacco de-addiction. Some facts about tobacco epidemic globally. It is one of the biggest health crises that the world is facing today. In 2020, 22.3% of the global population used tobacco. Amongst them, 36.7% were men and 7.8% women. It kills more than 8 million people each year, either through direct intake or secondhand exposure. Globally, about 32% of total cancers attributable to tobacco-related cancers occur in male, while 15% in female. Some facts related to India. Related to tobacco and India. India is the second largest producer and consumer of tobacco products in the world. 42.4% of Indian men and 14.2% females, accounting for about 28.6% of population, use tobacco in smoked or smokeless forms. Tobacco-related cancers contribute nearly half of the total cancers in males and 1/5 in females. A little bit about nicotine as an addictive substance. It's a powerful psychoactive drug. Its addictive potential is same or even more than heroin or cocaine. It resembles neurotransmitter acetylcholine, which acts on the neuronal nicotinic receptors. It causes widespread neuronal activation in brain, including the brain reward circuit. As a result, nicotine user experiences pleasure, reduced fatigue, increased alertness, reduced anxiety, and other reinforcing effects. When the person stops tobacco use, these chemicals decrease in the body and withdrawal symptoms start. They may be in the form of urge to smoke, depressed mood, insomnia, irritability, and anxiety, which typically peak at about 1 to 3 weeks, compelling the user to continue using tobacco and getting trapped in the vicious cycle. Different forms of tobacco. Smoked forms are cigarette smoking, which is the most common form of tobacco used worldwide. Hookah, cigars, pipes, bidis, most commonly used in India, and critics. Smokeless tobacco products are khaini, which is a mixture of tobacco and lime. Most commonly used smokeless tobacco product in India, followed by gutka. Gutka is a mixture of tobacco, lime, and areca nut. Jarda is a mixture of tobacco, lime, spices, and vegetable dyes. Betel quid with tobacco, that is pan with tobacco. Smokeless tobacco products may be used in chewed form. They may be sucked or sniffed. Now, approach to the patient. Not all patients who visit us are willing to quit. So those who are not willing to quit, we go with the 5 R's approach. First one being relevance. Encourage the patient to quit by indicating how it is personally relevant to him or her. Talk about the risks. Ask the patient to identify potential negative consequences of tobacco use. Ask the patient to identify potential benefits of stopping the tobacco use. That is the rewards he or she is going to get when they stop tobacco use. Roadblocks, what are going to be the barriers or impediments to quitting? Repetition. Whenever the patient visits, at every opportunity, we should be reinforcing the motivational message and reassure that repeated quit attempts are not unusual. Now, those who are willing to quit, we can go with the 5 A's approach. The 5 A's being ask, advise, assess, assist, and arrange. I'll be talking about these in much more details in the upcoming slides. Ask all persons whether they use tobacco. Elicit a brief history of tobacco use in form of type of tobacco they use, quantity, first use, first daily use, and complications related to tobacco use. Now, advise. Give a clear message, a strong message, and sometimes maybe a personalized message. Clear message may be in the form of, I think it is important for you to quit tobacco now, and I can help you. And you can add saying, cutting down while you're ill is not enough. A strong message may be in the form of, as your health carer, I need to advise you that quitting tobacco smoking chewing or sniffing is the most important thing you can do for your health and your family's health. I can surely help you in this matter. A personalized message may be related to the tobacco use, to current health or illness, and or its social and economic cost, maybe motivation level or the impact of tobacco use on the family members. Here we can also talk about the benefits of quitting. Maybe we can, for example, we can tell them within 20 minutes, the blood pressure drops to normal, plus pulse rate drops to normal. Within 8 hours, carbon monoxide level in blood drops to normal. Within 24 hours to 48 hours, chances of heart attack decreases. So we can talk about the physiological changes that happen when the person quits. Assess. Here, the most important thing which we should assess is the willingness to quit. The stage of readiness for change model can be a valuable model in this regard. This is also known as a trans-theoretical model. It was developed by Prochaska and D. Clement in the late 1970s. Tobacco cessation is a process. It may go through the steps of being ready, quitting, relapsing. An average of 3 to 4 times, before achieving success, a person may, relapse 3 to 4 times. Tobacco users will be in different stages of readiness, different times. So it's important to reevaluate the readiness constantly. Talking about the stages of readiness for change model. So there are 5 steps, 5 stages: pre-contemplation, contemplation, preparation, action, maintenance. So there are different interventions at different stages of readiness. For example, in the pre-contemplation stage, this stage is when the patient is not ready at all. He's not considering quitting at all. He sees only the positive aspects of tobacco and do not like to acknowledge the disadvantages. So here we can encourage him or her to think about his or her tobacco use and make an offer to help. Maybe we can write a written information on the harms of it and benefits of quitting. Second stage being contemplation. Here the patient is unsure whether I should quit or not, or whether I should consider quitting. So in this stage, a person is amenable to brief motivational interviewing. Maybe we can talk to them about the relevant health effects of tobacco use, barriers to cessation, provide them written information, and inform them that quitting is possible with willpower and support. So talking about motivational interviewing briefly, it has 5 principles. First one being developing discrepancy. So here, when we develop, this means clarifying important goals for the patient, exploring the consequences of current behavior, creating a discrepancy in the mind of the patient between their current behavior and their goals. Express empathy is the second principle, meaning we should be listening to the patient. The listening to the patient should be skillful, reflective listening. We should be accepting towards the patient, be respectful towards them. Accepting does not mean agreeing. It just means just listening to the patient and not confronting. Client ambivalence is normal. Third principle is avoiding argumentation. As I said, resistance from the patient will be there, and we should avoid arguing with them. If at all this resistance arises, stop and find another way to proceed. Avoid confrontation with the patient. Rolling with the client's resistance. Whenever the resistance is encountered from the patient's side, the counselor should not oppose it outrightly. Instead, we can offer new information, alternative perspectives, giving the client respectful permission. Okay, take what you want and leave the rest. It's fine. Various forms of reflection that may be used are, for example, whenever we are encountering resistance from the patient side, We can use different methods like shifting the focus of discussion, reframing the client's observation, or maybe emphasize the client's personal choice or control. Instead of opposing, we can use various other forms of reflection. Supporting self-efficacy. We need to boost the patient's confidence that, yes, they can do it. Communicating to them that, okay, a strong sense that change is possible. Offering support to them for making a change. Brief intervention may also be in the form of frames. Frames is an acronym. F meaning feedback, giving feedback to the patient in form of scores of screening instruments, or maybe informing them about the risk associated with tobacco use. Responsibility, emphasizing on personal responsibility for change. Advice, clear advice to change in an objective and non-judgmental manner. Here, not judging the patient is very, very important. Giving a menu of alternative or treatment options. Therapist empathy is also very, very important. Facilitation of client self-efficacy or optimism also helps the client to quit. Now, the third stage, preparation stage. Here, the client is already ready. So most likely they ask for help with quitting. Action. In this stage, patient has already quit in the last few months, less than 6 months. It's not been more than 6 months that the person has quit. So the risk of relapse is highest. The interventions which are used here are basically to prevent relapse. If relapse occurs at all, it is important that this should not be seen as failure, but considered as a learning experience and as part of quitting process. Maintenance. So this stage, the person has quit for more than 6 months, so chances of relapse diminish over time. Only about 4% of those who quit for more than 2 years ever go back to tobacco use. So assessment includes assessing the willingness to quit and also the severity of nicotine dependence, whether it is low, moderate, or high. So this instrument which is used is Prager-Storm test, which is used for assessing the nicotine dependence. The score, if it's less than 4, it's low. Score 4 to 6 is medium. And if the score is more than 6, it's high. Now, assisting to quit. The first step here is to set a quit date with the patient. Discuss with the patient and set a quit date, preferably in the next 2 weeks. They may tell family, friends, co-workers about quitting and request their support. Challenges are going to be there because of withdrawal symptoms. They may be asked to remove tobacco products from environment, avoid smoking in places where they spend a lot of time, example, work, home, car, etc. Next thing which we can recommend is use of pharmacotherapy. We can give them some practical counseling, and provision of social support also assists in quitting. So I'll be discussing pharmacotherapy, practical counseling, and a little bit about social support. So practical counseling may be in the form of providing basic information about smoking and successful quitting, identifying what helped and what did not in the quit attempts, recognizing the high-risk situations. For example, negative mood may be a high-risk situation for a person. When he or she is in a negative mood, he starts smoking. When being around other smokers may be a high-risk situation for some person, etc. Learning to cope with your urges. This is very, very important. Here, I'll be discussing 5 Ds in the next slide. And developing coping skills, as in learning to anticipate and avoiding temptation. So 5 Ds to cope with the urges. Delay until the urge passes. Usually, the urge passes within 3 to 5 minutes. Distract yourself. Call a friend. Go for a walk. Drink water to fight off cravings. Deep breaths. Relax, close your eyes, and take 10 slow deep breaths. Discuss your feelings with someone close to you. These strategies may help you cope with the urges. The last point which was there in assisting the patient was developing coping skills to avoid temptation. So some coping skills which can be used by the patients are: avoid certain people and places that can tempt you to smoke. One. Second, use some other alternatives like switch to soft drinks or water if you're using alcohol or coffee. Take a different route to school or work if high-risk situations are there in this route. Take a walk when you used to take a smoke break. Other alternatives are using oral substitutes like gum, cloves, and so on. Exercise or activities which involve keeping the hands busy can also help you distract from smoking. Pharmacotherapy. Pharmacotherapy may be in the form of nicotine replacement therapy or non-nicotine replacement therapy. Now, nicotine replacement therapy is a method of substituting the nicotine in tobacco products by an approved nicotine delivery product. Doses monitored and gradually reduced to make the process comfortable for the tobacco user. So nicotine replacement therapy, the blood levels increase relatively slowly. Nicotine through tobacco smoke reaches the brain within seconds, but the medicinal nicotine takes about minutes to hours. So motivation and patience are essential to the tobacco user. Different types of nicotine replacement therapy which are used are gums, lozenges, nasal spray, inhaler, and patches. So nicotine gums are available in 2 milligram and 4 milligram strengths. So the dose which is started is 2 milligram every 1 to 2 hours for the first 6 weeks. Then it's reduced to 2 to 4 hours for the next, every 2 to 4 hours for the next 3 weeks. And then every 4 to 8 hours for the next 3 weeks. For those who smoke more than 25 cigarettes per day, the dose which may be used is 4 milligram and up to a maximum of 24 per day, 24 gums per day maybe. Those who chew tobacco, that is smokeless forms, need about half or quarter of the dose as prescribed for smokers. Patients should be maintained on an optimal dose of NRT for 6 to 12 weeks, followed by a reduction for another 6 to 12 weeks. Those who are strongly dependent users need longer period of NRT to prevent relapse. The instructions which may be given to the patients are to advise all tobacco products once they start using the gum on the quit day. Chew gum slowly until there's a tingling sensation, then park the gum between gums and cheek until tingling sensation stops. Start chewing the gum again when the tingling sensation stops. Continue parking and chewing process for about 30 minutes. And the person is not supposed to eat or drink anything 15 minutes prior to and during the use of the gum. Absorption is through buccal mucosa and it's decreased by acidic environment. Thus, patients are asked not to use coffee, soda, juice, etc. immediately before, during, or after gum use. Some common side effects due to nicotine gums are soreness of the mouth and jaw, burning in the mouth, throat irritation, nausea, vomiting, hiccups, and excessive salivation. Tolerance may develop to these symptoms in a few days or so. Contraindications are gastric ulcer, unstable cardiovascular disease, that is in immediate post-MI period within 4 weeks, serious arrhythmia, severe or worsening angina pectoris, and severely uncontrolled hypertension. Nicotine lozenges. They're similar to gums, available in similar strength as gums, 2 milligram and 4 milligram. 4 milligram is preferred in highly dependent smoker. But lozenges, they deliver 25% more nicotine because some nicotine is retained in the gum and nicotine is resolved completely. Lozenges preferred by those who use gum because of dentures, who cannot use gum because of dentures, or maybe pain in the temporomandibular joint, or maybe they don't prefer chewing gum. Nicotine patches, these are longer acting. They deliver nicotine more slowly, convenient to use, but they're not as easily available as gums. And they're not as cheap. The preparation which is available is 21 milligram, 15 milligram, and some 7 milligram. Some patches last 16 hours and some last 24 hours. For persons smoking more than 20 sticks per day, the 21 milligram patch is recommended once daily. It's applied to a clean, dry, hairless area. Patients usually they use patches at a steady dose daily for 6 to 12 weeks, then taper slowly using low dose patch over an additional 6 to 12 weeks, followed by no patch. Most common side effects are skin rash, where it is applied, and insomnia. In those having insomnia, we ask them not to use the patch during the night. Nicotine nasal spray. It comes in a handheld spray bottle. Begin using on a quit date. Now, how to use it? Blow your nose to clear it. Breathe through your nose. Then tilt your head back. Spray once in each nostril. Do not sniff, swallow, or breathe in while spraying. Wait for 2 minutes for nicotine to absorb before blowing your nose. Now, the usual recommended dose for this is 1 to 2 doses per hour for 8 weeks, with a minimum of 8 doses per day and maximum of 40 doses per day and maximum 3 months use. Between 9 and 14 weeks, a gradual taper is recommended. So nicotine nasal spray, it achieves peak venous nicotine level within 4 to 15 minutes. It's faster than any other NRT. That's why it has abuse liability. Nicotine inhaler, here the nicotine is absorbed through the buccal mucosa. Peak plasma concentration achieved within 15 minutes. Recommended dose is 6 to 16 cartridges per day for 12 weeks with a gradual weaning over 6 to 12 weeks. Each cartridge contains 10 milligram of nicotine and delivers a maximum of 4 milligram of nicotine. One cartridge provides 20 minutes of active puffing. Now, how to use this? It should begin on the quit date. Begin using on the quit date. Take short, shallow, and frequent puffs to allow nicotine to absorb through mouth and throat. Do not breathe in deeply into the lungs. Do not eat or drink during use or for 15 minutes before use. Non-nicotine replacement therapy, bupropion. It's an antidepressant that has demonstrated an efficacy in smoking cessation. So it acts through dopaminergic and adrenergic actions. It reduces the urge to smoke and reduces symptoms from nicotine withdrawal. Approximately doubles the odds of success in quitting. It's effective in those smokers who have depression, cardiac disease, and respiratory diseases, including COPD. It's available as 150 sustained release 150 milligram tablets, cost of which is 6 to 7 per tablet approximately. It's initiated as a single tablet first for the first 3 days, followed by 150 milligram twice a day from the 4th day onwards, then continued for the next 7 to 12 weeks. This should not be used more than 300 milligram per day. For smoking cessation, for depression, it's used as at a higher doses also. This should be started. It's to be started while the person is using tobacco. Quit date is decided, preferably within 7 to 14 days of starting treatment, because the steady state concentration takes time. It takes about 8 days. Bupropion sustained release can be used in combination with NRT. The side effects are restlessness, insomnia, GI upset, appetite suppression, and weight loss, headache, allergy, lowering of seizure threshold. It's not recommended in those people with epilepsy, those taking concurrent psychiatric medication, those with eating disorders or pregnancy. Varenicline, it's a partial agonist of nicotine acetylcholine receptor. It maintains moderate levels of dopamine to counter the withdrawal symptoms and reduces the urge to smoke. So it's the most effective pharmacotherapy, 3 times more likely to succeed. So smokers using varenicline are 3 times more likely to succeed in short and long-term cessation compared with no medication. So the dose is to begin at 0.5 milligram OD for the first 3 days, followed by increased to 0.5 milligram twice daily for the next 4 days. On day 8 and beyond, the recommended dose is 1 milligram twice a day. Nearly 1 week is required to achieve steady state, and quit attempt should occur in the second week of treatment. And the treatment is continued for 12 weeks. So all this while we were talking about individual intervention, but individual intervention alone is not going to help, because tobacco epidemic has to be handled at community level, national level also, if we really want to control, if we want to fight against tobacco control. So at community level, what can we do? We can increase the price of tobacco products. We can conduct mass media education campaigns. We can make regulations regarding restricting smoking in public places, involve youth in anti-tobacco advocacy, increasing the knowledge and awareness about the harmful effects of tobacco use among the people. At national level, what can be done? Comprehensive bans on tobacco advertising and promotion can result in considerable reduction of tobacco consumption. Increasing taxes on tobacco products can help. Encourage tobacco cultivators to switch to alternative crops, etc. Just talking in brief about the M-Power policy by WHO. So M-Power here, M stands for monitoring tobacco-related issues. P is protecting people. O is offering help. W is package warning, like warning in form of package warning labels and counter tobacco advertising. E is enforcing bans on tobacco advertising, promotion, and sponsorship. R is raising the taxes related on tobacco products. So this policy was introduced by WHO 15 years ago, and the recent report which was prepared by WHO says that most countries are making progress in their fight against tobacco control, but we really need to accelerate our efforts. So thank you. These are the references I've used.